to think of it as a rusty nail, but if somebody comes in with a bite, so typically where you're bitten, you start with a little bit of spasticity. So this patient had a little spasticity near his foot, and then it progressed. The life-threatening situation is when you get these glottic spasms in patients in asphyxiate. As I mentioned, there's a lot of autonomic instability, and the hallmark of this is just a normal sensory exam and normal cognition. So if the patient is able to talk, they're usually very lucid. That's how you can differentiate it from meningitis or encephalitis, where you might have a depressed mental status. This is all peripheral nerves. There are no hallmark lab findings. You often will not see leukocytosis. And then management principles are really stop the toxin production, because bound toxin is irreversibly bound. You can't get rid of it. So all you're trying to do is stop the toxin production and then mop up any residual toxin that's floating in your bloodstream before it can attach to the nerves. Once it attaches to the nerves, you really have to wait for the nerves to regrow their nerve ends. So neutralizing it that's the rationale for immunoglobulin. And then airway management for patients who are particularly sick and controlling the spasms. So when somebody's hypersympathetic, any stimulus can set off a wave of tetany. So oftentimes we have to sedate these patients, put them in a dark room, not disrupt them much. So this is just some of our notes from the chart in Tanzania. This patient got tetanus immune globulin, penicillin, got treated and cleaned out until it was nice and healthy tissue. We put him on bed rest, sedation, and he made a full recovery. And when he was able to talk, he told us that he had been bit by a dog about a week prior. So he came from a bite, and he gave permission to use suspicion. Okay.
Did you see on skin down bite chart?
Yeah, he actually had a bite on his heel. Okay. All right. So this is any other questions about tetanus?
Yeah, I don't really get how the repeat immunization helps.
Oh yeah, it's a great question. So so first I'll say tetanus is one of the few bacterial diseases that doesn't confer natural immunity after you've been infected. And then we think that the tetanus vaccine is fairly efficacious, though we know that the efficacy wanes over time. And it's basically a risk balance of, if this wound is fairly high risk for tetanus, we should just take the vaccine.
Doesn't it take a couple of days or weeks to get any?
It does. So it probably takes about a week, which is the reason why if you're really worried about it, that's why you give the immune globulin. So the globulin mops up the toxin while you're waiting for your immune system to kick in. Yeah, good question.
Just a quick question. The case the person was afebrile. Usually, are they febrile because of they're contracting so much?
That's true. That can produce pyrexia just from muscle contractions. But classically, if it's a toxin-mediated process, similar to botulism or other diseases, they often don't have fevers. Yeah.
What's the survival rate if the person progresses to the point of having the back arching?
Yeah, opisthotis. It's pretty good if you can get treatment into them, but obviously, immune globulin is a precious resource, and if it's not available, it's a high fatality rate. Yeah. Okay. So this is another case that I saw. A 45-year-old man in his usual state of health, minding his own business, when his wife yelled that there was a lion outside the house.
Oh.
And he tried to chase it away, and it chased him. Then he climbed a tree, and then he fell out. And then the lion fell. Okay, so you have the question, Doctor, what would you like to do with this? And this is just my example of what happens when you get bitten by a lion or a cat or a dog or something. Okay. So puncture wounds in general. So the main thing to remember is immediate copious irrigation. So if you find yourself, out in the wild, you're climbing, camping, you get a puncture wound, you just want to wash it like crazy. Saline is preferable. If you feel like you can actually get, evac to an emergency department within an hour or two, just plain old water is fine. At some point, if you see somebody in the emergency department, you probably want to trim the jagged edges of the wound so it heals nicely. The other principle is just removing foreign bodies. So if there's glass, needles, etc., if they need plain films to look for those foreign bodies, do that. You do not suture the wounds, so you just let them heal by primary intention. And they will close up on their own, so you don't create an anaerobic pocket in there. And then you think about tetanus prophylaxis. Now, in this case, would you give antibiotics?
Yeah.
What do you think?
A lot of bacteria.
Lion's mouth is dirty. Okay, sounds good. What about other animals? What about like a dog bite?
Yeah.
What's that?
Pastorella.
Yeah, so here, pastorella. You're wondering if that's dogs or cats?
No, I think it's both, but it's possibly.
Yeah, absolutely.
Would you do a rabies vaccine?
Great, good question. We'll get into that. Absolutely. Okay, so high-risk bites. Okay, so in general, deep puncture wounds. So not superficial bites, but deep puncture wounds. And the thing is, cats and lions, I don't know, are there any cat owners here? You? Yeah. As you know, they have very sharp, pointy front teeth. That's different from teeth of dogs, which tend to be a little more flat. And so when cats bite you, they get down into the tendons and they pull those teeth out, and it creates this nice anaerobic pocket for things to grow. Dog bites tend to be open a little bit more, and so the risk of infection is less. So the risk for an infection, if you get a real cat bite, not just a little scratch, we have like 90% of those wounds will get infected. Whereas dog bites, even if it's a real dog bite, it's probably closer to 20%. So cat bites definitely get prophylaxis. The other times we give prophylaxis if there's a significant crush component, if it's on the hand or near a joint, those are easily seeded by bacteria, if they need surgical repair, and if they're immunocompromised.
What about bears?
Good question. I think if you're asking the question, you probably need some sort of antibiotics, because probably bears cause a lot of crush injury and mauling. So that's probably right. So case by case basis, but they're on the screen. Yeah.
What about the question you're hunting underneath antibiotics?
The problem is when you have crush injury, you've got a lot of death in the muscle tissue, and that's just a nice medium for bacteria to grow. Okay. So not everybody gets infected, as I mentioned. The microbiology, as you guys alluded to, it's usually either skin flora, so staph or strep, or oral flora from whatever's biting you. It tends to be polymicrobial, and you guys already mentioned the one particular bacteria that tends to be isolated from other cat bites, which is Pastorella. Again. Any other bacteria that you learned? Bartonella from cat scratches, right? Kiffin syndrome. Yeah. What's that? Yeah, what is that? Capno. Yeah, Capnocytophaga. Good. So Capnocytophaga canamorsis, which is probably something you never heard about. I just saw a case of it 2 weeks ago when I was on service. After a dog bite, it causes fulminant sepsis, usually in patients who don't have a spleen, but it is a great bug to know for the wards.
Is it encapsulated?
That's a great question. Actually, it's not encapsulated, so I don't know why patients without a spleen are in higher risk. Good question. Okay, so Pastorella, as you know, it's a gram-negative rod and can cause progressive cellulitis, soft tissue infection. We often see a tenosynovitis if people get bitten on the hand, so it can be quite impressive. Does anybody know what you might treat with or prophylax with? Yeah, augmentin. And what is augmentin? Yeah, amoxicillin clavulanate. Right. So that tends to be first line. That's usually what we give in the emergency department. If somebody is allergic to amoxicillin, there are a few other things you can give: doxycycline, Bactrim, Moxie. Usually, you give those with something with anaerobic activity, so metronidazole or Quinda, to get those oral anaerobes. And you should just treat for 3 to 5 days. Skin infections, you don't have to treat very long.
So augmentin by itself has anaerobic coverage?
Yes. Yep. It's a great drug. If any of you are going into ENT, that's like the only drug you need to know. Augmentin or its counterpart Unison, just ampicillin, Bactrim. Yeah. Sometimes okay. Another dog bite. This is an 18-year-old man brought in by family for confusion, aggressiveness, and headache. Worsening over the past week to the point of obtundation. He has intermittent fevers. And his mother reports that he was bitten by a dog 2 months ago. And 3 days ago, the patient actually bit his mother in the case that I was involved with. Yeah. So, what's that?
Yeah.
Good question. Why do you ask?
Rabies.
Right. So you're concerned about rabies, appropriately so. So the question here, this is an example of a second order question on the boards where they're not asking you what the disease is, but they assume you know what it is, and then you say what do you want to do about it. So is it too late? When is it too late to give rabies post-exposure prophylaxis? 1 week, 1 month, 6 months? No.
Yeah.
Never, you just give it. What's that? When it reaches the CNS? Okay.
I thought rabies.
So it sounds like there are a few different answers, which is great. So it's a good discussion point. The answer is actually never. It is never too late to get rabies prophylaxis. Let's talk about rabies. This is a viral infection transmitted by animal saliva and causes a progressive encephalitis and death. It has the notorious distinction of being having the highest case fatality of any infectious disease. And there's this asymptomatic incubation period, which has been described for going on as long as 6 years, which is why there's no limit to when to give post-exposure prophylaxis. It's completely mysterious, but cases have been described after 1 year, 2 years without any other intervening risk factors. So the duration correlates with distance to the brain and the inoculum. So if somebody gets a small bite on the foot, it may take a lot longer to progress up the nerves to the brain than if you get bitten in a highly vascularized area like the face or the hand. Usually the incubation is about 1 to 3 months, but it can be days or years, as mentioned. And similar to tetanus, it goes up the peripheral nerves. So first you get this prodrome, this flu-like illness. You may or may not have neurologic symptoms. There's a sort of classic finding of myoedema where if you percuss somebody's muscles, those muscles will swell. Don't ask me why that happens. That lasts for days. And during this prodrome, post-exposure prophylaxis can still be effective. So even if somebody gets bitten and they develop flu-like symptoms, or you're concerned that they're getting sick, you can still give them post-exposure prophylaxis. Very high mortality rate. You guys heard there's a radio program called Radiolab.
Yeah.
Have you heard that the rabies episode? It's really fascinating, right? Yeah, that's about a woman who actually survived. So there are two main types. There's sort of furious rabies, and that's where you get these buzzwords, as you guys mentioned, hydrophobia, aerophobia. That's when you have these glottic spasms in response to air or water. That is virtually pathognomonic for rabies. So if you happen to see that on the boards, or you see that in real life, that is rabies. There's another form of rabies that occurs less frequently, but it's more paralytic syndrome, sort of like Guillain-Barré. So you get this myelitis first, and then you get encephalitis afterwards, and there are all sorts of atypical complications. Okay, next question. So a 4-year-old girl wakes up and finds a bat flying around her room. She denies being bitten, and her parents can't find evidence of a bite. The bat flies away. What is the next best course of action? You start immediate post-exposure prophylaxis. You test her for rabies antibody. You try to capture the bat and send it for testing, or do you provide the family with reassurance and close observation? A. Why do you think A?
I feel like it's better to give it and be safe than to ever develop symptoms.
Okay. Great. I like that. So you're absolutely right. Initiate immediate PEP. Also, for the budding pediatricians out there, if you're dealing with a 4-year-old, you know you're dealing with parents who are just in a panic. So a little bit, I'm just going to talk about rabies in general and then locally here. So dogs are the most common vector worldwide. It's very common in wild animals in the United States. So rabies is absolutely here in the U.S. There are a number of medical visits for post-exposure prophylaxis. So you're much more likely to see somebody in ED urgent care for post-exposure prophylaxis rather than rabies. But actual infection is quite rare. We really see 1 to 3 cases in the U.S. per year, though worldwide there are innumerable cases. And it's probably either because PEP works or most bites are not infectious. So this is CDC data. This is the most recent count. These are just animals that the CDC samples for rabies. And the size of the yellow circle correlates to number of animals that were found to have rabies. And the shade of the state or the county correlates to how many animals were tested. So you have sort of had a sense of the denominator. Clearly, they're testing a lot of animals in California, and there are a lot of rabbit animals. And you can see all these yellow dots in our state showing that rabies is here. And it's obviously a lot on the East Coast. That brings me to the next slide, which is what are the vectors of rabies here? So, okay. So let's take sort of the Northwest and Midwest region. What do you think is the most common animal, excluding bats? So, skunks, raccoons.
Chipmunks.
I love it. Okay. Skunks. Okay. What about this area? Foxes. And East Coast? Any East Coasters in here? No.
Pigeon.
Exactly. Business carry on these little stuff. And what about Puerto Rico and the DR? The mongoose. Okay. So this is data I just pulled from the Department of Health website showing that these are bats that were tested for rabies in the last year. And within Snohomish and King County, there were 2 bats found to have rabies. Okay. So roughly 5 to 10% of bats that are submitted for testing test positive. That's a skewed population because it's usually sick or injured bats that are tested. We don't have any rabid dogs in the state that we know of, but there can be imported cases. And there are 2 cases of human rabies in Washington in the last 20 years. One was that 4-year-old who died 4 weeks after finding a bat flying around in the bedroom. And the other one, the exposure was unknown. So bats, it's not clear whether they lick or saliva somehow gets on you. But you do not need to be bitten. And And this is one of the main reasons why the U.S. guidelines say give post-exposure prophylaxis if there's any bat contact when you are unconscious. So if you can't rule out a bite, you have to give post-exposure prophylaxis.
So what if you're like a animal worker vet, or if you're traveling to like another country with very high lot of bats,
Yep.
you get prophylaxis, and how long does that last?
Great question. So we'll talk about the vaccine. Yep. Perfect question. So there is a vaccine. It's inactivated. So if you're anticipating a high risk exposure, you're a vet. I think I have the indications on the next slide. You are eligible for the vaccine. Then the other form, so similar to tetanus, there's also rabies immune globulin. And you basically give the immune globulin while waiting for your body to generate the antibody. And you generally give the vaccine and the immune globulin at different sites so they don't bind each other. Okay, so the questions when I think about rabies are, did a mammal bite the patient? Did the patient's open wound, broken skin, or mucous membrane contact saliva? And did the patient have direct contact with a bat in which a bite or a scratch cannot be ruled out? If yes, then you go through the following algorithm. So first you, in general, this is the guiding principle, you irrigate the wound immediately with soap and water. If the animal is, I love that they say if you capture the animal, do so, and then somehow bring it to the emergency department. Like the emergency department is going to know what to do with it. So I tried to break down the algorithm a little bit. So high-risk wild animals include bats, raccoons, skunks, foxes, coyotes, bobcats, woodchucks, not squirrels, not pigeons. Okay, animals with fur. So if the animal is not available to test, then you give post-exposure prophylaxis. If they are available to test, then, which means you take them to the vet generally will sacrifice the animal, look at its brain, if it's positive for rabies, then you get post-exposure prophylaxis. If it's negative, you don't have to do anything. Okay, for other like household animals in general, like cute animals, we try not to kill them if needed, so you quarantine them. So if they're healthy and available for quarantine, after a 10-day quarantine, and they're still healthy, no post-exposure prophylaxis. If they're not available, they have ran off, you don't have vaccination status, you start post-exposure prophylaxis. So in general, most animals, most domesticated animals have had the rabies shot. their owners taking care of them, so they tend to be pretty low risk.
What if it's a healthy animal but that you close to your head?
Close.
Like closer to your head, so you might not have it.
You still probably have, a month, so it's not. So that's why that's maybe quarantine.
Do you do the quarantine even if the animal's been vaccinated?
No. No. Yeah.
I'm just wondering, since rabies has such a long incubation period, why 10 days as the rule out?
In general, we think that if an animal bites you, it's probably because they're rabid, and so they should develop symptoms. They should be in the symptomatic phase, and those symptoms should be self-evident.
Is it still transmissible if they were in the incubation phase? It just be.
Yeah, it's a good question. It should. Yeah. It's a mean animal. It can be hard to sort out. It really only becomes transmissible when it reaches your brain and then gets secreted in your saliva, so not before then. Yeah.
So anybody that gets bit by like a mammal should get rabies prophylaxis, or
It again totally depends on what the circumstances are. If they're, if it's a domesticated animal, generally no. If it's a wild animal, the main thing to do, the main take home is, we always call the Department of Health, and they will give us guidance. But there's a lot of costs associated with immune globulin and the vaccines. You can spend $3,000, and obviously if it's life or death, that's insignificant. But it would just call the Department of Health. We probably overprescribe post-exposure prophylaxis. So, but if you're out in your yard and you get hit by a skunk or raccoon, we take it seriously. Okay. All right. Rabies in the American wilderness. It's rare, it's devastating, and it's usually prevented. When in doubt, always. Okay. So getting back to your question about vaccinations. It's generally not routinely recommended to vaccinate people unless you're a caver, so significant bat exposure, or you're some sort of wildlife handler. And then when we counsel people on travel vaccines, there are very few people who actually need the vaccine when you travel. So those of you who are thinking about going abroad this summer, it's probably not indicated unless you're really going to be around wild dogs somewhere for a prolonged period of time. But if you're going to an endemic area and you don't think there's access to immune globulin, then you could certainly consider it. So getting the vaccine doesn't mean you don't need to do anything about a fight. It just means you don't have to get immune globulin after you've been vaccinated if you've had an exposure. Does that make sense? Any questions? Yeah.
How long does the rabies vaccine last for?
That's a good question. Nobody knows for sure. If you have repeated ongoing exposures, probably the best thing to do would be to check an antibody level, after 10 years or something. So if you're at that, you probably need it periodically. But if your antibodies are low, then you need to vaccinate. It's probably not lifetime. Okay. Take price. All right. Does anybody know, just in general? Yeah, rattlesnake, good. Very good. Okay, so these are rattlesnakes. They're multiple species. They are endemic in pretty much every state of the U.S., with the exception of Alaska, Hawaii, and my home state of Maine. They have a triangular head and these evil-looking elliptical eyes, and they have this heat-sensing pit in the middle, which is why they're in general called pit vipers, because of this heat-sensing pit. And at night, they know that you're in your tent. So you're into it. And they have this banded tail, but just remember that a lot of them actually don't have a rattle because it may have either been damaged due to trauma or if they're a juvenile snake, they may not be fully formed. So if you don't hear the shaking, it doesn't mean that it's not a rattlesnake. Okay. Anybody know what this is? Washington. Good. Yeah, good. It's the western rattlesnake. So this is our local viper. It's found in eastern Washington only, not on the side of the Cascades. And the main things to distinguish it, it's got this triangular head where the head is really much wider than the body. This diamond pattern, which can really vary by season, it has rattles. And the color can really change depending on its habitat. It sort of varies between gray and brown, so it can be very hard to identify whether it's actually a western rattlesnake. This snake, anybody want to take a guess? This is a cottonmouth. So this is found sort of in the southeast United States, so Virginia to Texas, also known as the water moccasin. It has this very blunt nose, and then the main thing that distinguishes it from the copperhead is this big, broad stripe that goes from its eye to its neck. But again, it can be hard to distinguish. This is the copperhead. But the colors, again, can change, so it's not quite that dramatic. This is a much broader habitat, so really, Massachusetts to Texas. And the nose is a little more flat, so the nose goes down and then up. But otherwise, I'd say hard to tell apart. There are all these historical ways that people have thought that they can tell poisonous from non-poisonous snakes. And so the snakes that sort of look evil with these pupils and these big fangs, people will say are poisonous, and the harmless ones are sort of smiling at you. I would not rely on this. I know that. There's still textbooks that have that picture. So in general, the way to think about it is rattlesnakes can cause more severe signs and symptoms than cottonmouths. And copperheads usually is just limited tissue swelling without systemic symptoms. Okay, question. So you and your friend are hiking around Lake Chelan. When you hear a rattle and see an evil-looking snake with eyes, your friend who has not heard this talk decides to try to pet the snake and put it in the hand. At 1 hour, you note edema that has progressed to the wrist. And your friend is complaining of mild nausea. What is the next best step? Do you apply a tourniquet, try to suck out the venom, be back to the ED for labs, be back to the ED for immediate antivenom? I've heard almost everything except D.
No, never mind.
Anybody want to put their ankle down?
D.
Okay, so I hear D. So we're going to talk about C and D. So the answer here is C. Okay, and that's not usually on the boards they want you to do something, right? Usually they just want you to skip the labs and just give me a antivenom. Here are these labs. So in general, I mentioned the rattles not sounded first. Wear heavy shoes, and remember they like to heat at night, so just protect your sleeping bags, your boots, make sure everything is closed up when you leave the tent. So in general, these can cause a lot of local tissue damage. They can cause non-specific GI symptoms. When it gets more severe, you see coagulopathy and hemorrhage, and then rhabdomyolysis, so muscle breakdown. The myoglobin goes to the kidneys, and then that causes renal failure. And then all sorts of capillary leak or vascular permeability issues leading to shock. And some snakes, which we'll talk about, have neurotoxicity associated with them. So how do you decide what to do? You wash the wound. You always go to the emergency department. Keeping in mind that in this case, you don't want to speed up your friend's heart rate too much because that can kind of wash the venom around. So you try to immobilize the limbs. It's actually sort of a complex decision whether to raise it or try to keep it below heart level. So it kind of depends on your timing. So if you keep it below the level of your heart, the venom will kind of sit in the arm and probably cause a lot of local tissue damage. Whereas if you keep it elevated, it'll probably minimize the tissue damage here, but you might encourage it to go into systemic circulation. So in general, you just try to immobilize it as best as you can. There is if you take away one thing here, there's no role for sucking out the venom. Don't apply a tourniquet, you usually do more damage. No pressure dressings, just wash it and leave it alone. And yeah.
I was curious about the pressure dressings. I thought is that standard of care for other types of snake bites? Like, I know in Australia that's commonly recommended, but they also don't typically have bit fibers. Yeah,
I would say there's a lot of bleeding. That's usually when we put the pressure dressing on, but otherwise, we just leave it open. Okay, so about a quarter of them are dry bites. There's no venom associated. Usually the venom causes a lot of edema, pain, and blistering. And if you have proximal spread of symptoms, that usually means there's some progressive systemic toxicity that's about to happen. If you have systemic symptoms, so renal failure, coagulopathy, that's when you're in trouble, and that's why you go to the emergency department to look to see whether you have symptoms or evidence of impending symptoms. These Mojave rattlesnakes, which are found in Arizona, they don't actually cause a lot of local symptoms. They cause neurologic symptoms. They can cause clotting paralysis. And the toxin can work over a long period of time. So you actually have to obs them for 12 hours in the emergency department after a bite to make sure that they're not going to have some sort of bad neurologic outcome. So you're looking for venom syndromes. You're doing supportive care. Because of all the tissue edema, you can sometimes develop compartment syndrome. Are you familiar with compartment syndrome? So that may be a surgical indication. And then there are antivenoms that are available. Of course, you're going to give them a tetanus shot, and you do not usually need to give them antibiotics. So just a word about antivenom. It's a polyvalent IgG, so it has activity against western and eastern diamondbacks, the Mojave rattlesnake, and the cottonmouth, so the snakes that we talked about, which generally works well. And it neutralizes the venom that's in circulation, but not the stuff that's already bound. Sort of a theme for antivenom and immune globulin in general. And it tends to have a shorter half-life, so the venom can actually work longer than the antidote. So patients may need to be redosed. That's why you absorb them for a long period of time if you're going to give them antivenom. So the general indications for antivenom would be if there's a lot of swelling, a lot of local soft tissue injury progressing, or there's bleeding times are prolonging, so a high PT, low platelets, low fibrinogen, signs of BIC, any systemic signs. And the reason we don't give it to everybody is because there's a high rate of allergic reactions to the anaphylaxis. So just like you're ready. And then usually chat with poison control toxicology. You guys doing okay? And in general, it's pretty amazing. You know, if the patient has coagulopathy and they're bleeding spontaneously, you can usually reverse it in about 20 minutes. Okay. Other stinging insects. So you're watching a friend as he rappels down a technical rock face, and he steps into a beehive and is stung repeatedly. He lets go of the rope, and his auto block stays tight, and then he starts screaming about being allergic to bees. And you think, well, I really feel bad for you, but I really wish you had told me that earlier. So stinging insects. Pretty much everybody is going to develop some sort of local reaction. And it usually lasts for 1 to 2 days. If it lasts longer than that, then you start getting concerned about various mechanisms of allergy. And then just know that about 10% of people will develop large local reactions. That doesn't mean you have a particular allergy. That's just a super response to the sting. So usually what we do to supportive care, and this is just kind of the latter, start with cold compresses, NSAIDs. You can do topical steroids. You can do oral antihistamines like Benadryl or Zyrtec. If it gets really bad, then you can give them oral steroids just for a short course. So what happens with anaphylaxis? So about 2% of people have this IgE-mediated anaphylaxis. And the diagnosis is obvious eventually. Early diagnosis can be a little challenging. Sorry, trouble with my clicker. Adults are much more likely to die of anaphylaxis than kids, probably because they are taking medication for it. The treatment of choice is epi 1 to 1,000 diluted. That's different from epi that's in the coat parts that we give to patients for coating on the floor. And you repeat this every 5 to 15 minutes. Has anybody had experience with EpiPens for anaphylaxis? Have you had to inject yourself? Any problems with that?
Well,
Aside from the anaphylaxis part.
well, I don't know. It felt weird, and then I felt really sleepy. So.
Yeah.
Because I took Benadryl.
Yep. And a lot of people, it's hard. If you're new to an EpiPen, it's good to really read the instructions because a lot of people just stick themselves in the thumb or, display it incorrectly and then you unfortunately end up wasting it. And now they're really expensive. and try to get to the emergency department. So just remember that all these other medications, steroids, Benadryl, whatever else, is not a replacement for epinephrine. Epinephrine is a treatment for anaphylaxis. These others can help with biphasic reactions or other symptoms associated with anaphylaxis.
I have a quick question.
Yes.
I don't know if this is at all true, but I've heard that like inside an EpiPen, there's like more like epinephrine that isn't actually deployed, and you can like open up the cartridge and there's like more doses. Is that at all true?
That's interesting. I've never heard that.
Yeah,
Miles?
there is. You cut it open, you have like a syringe, you can draw out another 0.6 milliliters of it.
Oh, wow.
It doesn't compress all the way, you just fill up over.
Okay.
That's true.
Oh, so just always carry a drink.
Yeah. Yeah. Very, yeah. Not sketchy at all. Has anybody seen a scorpion? Yeah.
Yeah.
They're pretty cool, right? I saw one recently, and they fluoresce under black light, which is weird property. Okay, so there are many scorpions, but the bark scorpion is really the one that's most common in the U.S. Tends to live in Mexico and the southern U.S. And in general, it causes paresthesias, anaphylaxis. Sometimes there haven't been any fatalities in the U.S. since 1968. And my only advice is just check your boots before putting them on. They're not that big a deal. I don't remember if I had a slide about scorpion antivenom, but we don't use it that much, though there are better products that are on the market now, and they have a lot of experience in Mexico and Arizona with it. Any comments about that?
Oh, I'm just wondering if you get like stung by something or like if the stinger is still in, do you pull it out, or like is there a good way to pull it out? Because I'm sure that pulling out these things, you actually end up injecting more into yourself.
Right. Right. Was there a comment about that?
I've heard that you can use like a credit card to help pull it out.
Yeah, I've always just used tweezers. I mean, it has to come out at some point.
Well, that was just, I mean, that's a wives' tale I've heard.
Yeah.
I just didn't know if it was actually.
Yeah. I mean, it causes so much pain to leave it, and local irritation that I generally just.
So with scorpions, it's usually the smaller ones that are more dangerous.
It's true.
I got it from, Arizona training. They can do these things
Yeah.
like at a young age. And actually, they're pretty common in Arizona. And one time, it just totally blended into our carpet at my house. My mom really freaked out.
Yeah. Yeah. So, were you raised in Arizona? So, did you put glasses under your crib? I don't know if you have younger siblings or not, but sometimes people put things under their kids' cribs because scorpions can't climb up smooth surfaces or something like that. So you have to basically build a little contraption so they don't get. They can climb rough surfaces, but not smooth surfaces. So you put glass. It's very interesting. Okay. Maybe we'll end on this one and then take other questions. So this is a 26-year-old man who goes to the ED after waking up with a hot, red, painful, swollen hand at his center. He saw a spider in his bedroom and he thinks that he's probably bitten. You tell him, A, don't worry, it's resolved. B, probably a MRSA. C, is probably a brown recluse. Or D, he needs immediate antivenom. You will absolutely see this on multiple rotations. B, C.
What's brown recluse?
It's a type of spider.
And they're scary, and they're the household spider, and they literally follow you. Oh, East Washington.
Oh, yeah.
So I'm just going to give you a little pearl right now. This is probably, even though this is a talk about venom, this is probably MRSA. So patients will come in. You'll learn to recognize this after you see 2 or 3 patients like this. Patients will come in. They've got a black eschar on their hand or their body, and they say, "I was bitten by a spider." And you say, "No, you have MRSA." That's what MRSA looks like, and people attribute it to being bitten by a spider because they can't make any other sense or any other reasonable explanation. But it's probably MRSA. Spider bites are incredibly common, and people have studied that. Saying that you have a spider bite increases your odds of having MRSA by So spider bites are rare. It's usually something like MRSA or another etiology. And locally, we have black widows, the yellow stack, and the hobo spider, as you mentioned. And they're generally very shy and they bite out of self-defense, so I wouldn't chase them. So I have lots more pictures, but I think maybe we'll just stop there and take questions.
So hobo spiders are indigenous to Western Washington?
So what we have here. So I think the yellow stack we have. Hobo, I think maybe in eastern Washington. Yep.
My dad got bit and he had like a necrotic, like, he was really gross.
Oh.
In Eastern Washington.
So what do you do for spider bites?
Generally nothing, unless there's a lot of necrotic tissue that you have to debride. Otherwise, you just wash it, and you watch for local toxicity, but you don't have to do much about it. No.
What about black widows? Is that not true that they're like actually deadly?
Yeah, I mean, it depends what type of spider. Fortunately, in Washington, you don't have to worry about them too much. If somebody, I would, watch somebody closely, and if they're having any signs of systemic toxicity, then you go to the emergency department. But usually, spider bites are not that big a deal.
Isn't it usually like you're more worried when it's a kid that could have gotten bitten by a black widow?
I suppose the relative dose of venom for a kid versus an adult is different. And I'm always more worried about kids, so I agree with you.
So for the patients that come in, it was like for the last case, right, that you said that it's probably MRSA. So how did they initially get like the injury? Could have been just caused by anything, and then they just became infected?
It usually starts as a little folliculitis,
Okay.
and then the hair gets infected, and then it turns into a furuncle, and then an abscess, and then become necrotic. And that can happen pretty quickly, and the patient just may not have noticed it. So either there's an incidental scratch, or it just started with, a hair follicle.
Is there any test? Would you just culture anything that looks kind of like that?
Yeah, I would just culture it. You look for fluctuants, and you try to do incision and drainage if you can. It's over there. If there's not a lot of fluctuants, then you can probably just put them on oral antibiotics, for 5 days, and then just close follow and make sure it's going away. But I would treat presumptively for MRSA. Okay. Well, thank you guys.